Hi, I'm Carrie Priebe, Senior Director of Enterprise Access and Innovation. Today, I'm here with Lisa Brandenburg, our Chief Health Systems Officer, and Tim Dellit, our Chief Medical Officer. Lisa, it's been 6 months since we started our access journey. Can you refresh us on why UW Medicine has undertaken this effort?
Sure. And Carrie, as you know, I am very passionate about our opportunities to improve access. And I like to start with the big picture. And the big picture to me is that our work changes lives. And when we're not available to the patients that need to see us, we're not keeping our promise to the patients, we're not keeping our promise to the community. So in the area of access to outpatient services, we know patients want 3 things. The first is when they call us, they want us to pick up the phone quickly. The second is what you and I call first call resolution, meaning can we give them what they want in the first call? And the third is, can we give them an outpatient appointment in the time that they want? Well, it turns out, I think as many of us know, that we are not meeting the patient's expectation in any of these 3 areas. So what does our data look like? We have long wait times. When patients call us, we know that less than half of the patients are answering the call in 60 seconds, and many patients wait much longer. For first call resolution, we know that from a survey that about 28% of our patients call us more than one time to get what they need. That's frustrating for the patients. That's extra work for us. And in the third case, we know that in terms of giving patients an appointment in the time frame they need, we're not meeting that standard in many cases either. Our patient satisfaction survey scores show us in the 37th percentile when we ask them, are we meeting their access needs? These issues also lead to frustration for the faculty and staff who work here. And that happens in several ways. The first is that we all hear patient complaints about long waits to get to care. The second is that we have very high no-show rates in our clinics. That's frustrating for all of us. And one of the reasons is when we give patients an appointment that's too far out, they choose to go somewhere else, and then they don't call and cancel their appointment. And the third symptom we see is that patients get seen in the wrong clinic. That's frustrating for all of us. So we believe that as we fix our access problems, we are going to see significant improvement in all of these areas. And change is hard, but we must fix this to be successful.
Thank you, Lisa. Tim, we began this journey with Huron. From your perspective, how is that work going?
Well, I think Huron has been a great partner with this work. And in fact, the engagement actually started last spring in 2018 when we asked Huron to do a baseline assessment of our access. And not surprisingly, they found that we have challenges getting the right patient into the right clinic or with the right provider at the right time. Now, some of that is not a surprise. We're a big, complex organization. They found significant variability in our processes, our definitions, our metrics, from organization to organization, as well as even from clinic to clinic within the same organization. When we have that variability, it is really hard to get consistency to meet our access needs and appoint patients in a timely manner. Now, one surprising finding that they actually found was that when they looked at all of our templated hours in clinic, they found that 10% of them were actually listed as available but unused. And that was a surprise because it highlighted that we actually may have more internal capacity than we recognized, but because our system is so inefficient, we haven't been able to capture and utilize that for the benefit of our patients. Now, based on those learnings, this past September, we moved into the planning and implementation phases, and I like to think of it as different work streams. One of those work streams was to set standards and expectations across our system, and this is done through policy development. And again, these policies are a starting point as we go into our pilot areas, and then we'll learn from that information and be able to tweak those as we go forward. They're also helping us set standard definitions, standard metrics so that we have actionable data. They're also helping us restructure the contact center because the current configuration where we expect one individual to be able to appoint across over 120 different clinics is just not realistic. And I think as we restructure into pods with a specialty focus, but that is going to build the team between the contact center, the clinic staff, our clinicians, and really allow that to be a much more efficient process. So I actually think the work has gone extremely well to date. Now, Carrie, one of the things that we realized early on is that this is a lot of work, a lot of work. And so we need someone not only with our Huron partners, but we need an internal leader. And we are so grateful that you have agreed to lead our access efforts here and really work collaboratively with Huron. And so maybe you could tell us a little bit about what you've been doing as you've been partnering with Huron on this effort.
Thank you, Tim. I think you gave a great overview of the work that we've been focused on. As you know, I've been in my role about 3 months, and I'd love to share what I've heard from the organization, not only on how our work with Huron is going, but what else we could be focused on. The first is why we are here. We need to improve communication. We need to get to the organization, tell more people how the effort's progressing and how we're doing. You know, the second and most important is to improve the relationships between the contact center and the clinics. My team is building a dashboard to provide better transparency around how we're performing and serving both our patients and the organization. We're going to be launching forums to provide that data to UW Medicine and hear from you opportunities to improve and work together. The third thing is to develop a self-service strategy to ease the burden of cancellations and last-minute no-shows. We are going to improve our existing tools, our callback assist, our online scheduling, and make sure that our access tools are working the best that they can. The last thing that we've heard is we need clinical oversight and engagement in this process. And John Scott, our Medical Director of Digital Health, is now going to actively work with the contact center on quality improvement, on oversight on some of our tools so we can function the best that we can.
So Carrie, we're really excited about Go Live. You talked about it starting in April. Can you tell us a little bit more about what specialties are participating?
Absolutely. So I'm very excited to share urology and dermatology are going live at the end of April. So those are going to be our first 2 pilot areas. Our next 2, primary care and women's health, will go live at the end of June, followed by radiology in July. I'm also excited to share that we have selected our next 5 pilot areas, and those are neurosciences, rheumatology, nephrology, endocrinology, and then outpatient therapies, which includes OT and PT.
That's a great list. So Carrie, this is a lot of work. Thank you to you, your team, and everyone else working on this project for all of that work. I am really excited about our success. I think it's key for us now to be able to measure how we're doing, share that information with everyone, and work to hold each other accountable.
What does success look like in a year from now?
That's a great question. We have set some targets with the team that's working on this, and we're wanting to share them with everyone. So those targets for the first year, which are all great improvement for us, but not where we want to be ultimately, include what do our patients say about their access? We're at the 37th percentile now. We want to get to greater than the 75th percentile. For our service level target, we want the contact center and the clinics to answer 80% of our phone calls in 60 seconds. And third, for new patient appointments, we want all new patient appointments in the pilot areas to be scheduled in 15 days or less.
You know, I think from the physician side, the key is really being able to see the patients who need our services. And so getting that right patient into the right clinic with the right provider at the right time is really critical for our clinicians. We also think that it'll increase their satisfaction. They'll hear fewer complaints from their patients in terms of difficulty actually making appointments to be able to see them. We also think it'll be better utilization of the clinician's time when they're in clinic. If we can decrease our no-show rates, decrease the same-day cancellations, and better utilize their time to actually see patients while they're in clinics. And so I think there's a huge benefit for our clinicians. We also recognize this is challenging. This is going to be tough work, and we really appreciate the engagement of the clinicians in the pilot areas, the clinic medical directors, as we've worked to standardize duration of our visits. We look to standardize the appointment types. And standardize our templates. That is not easy, but our clinic medical directors have been very engaged, and we also recognize this is our starting point, and we will learn from these pilots. And so I think the clinicians, I'm just very appreciative that they've been so engaged in this effort to date.
Well, thank you, Tim and Lisa, for your time today. And, most importantly, thank you to everyone who has participated in this effort. We recognize that this effort has felt fast for many of you and too slow for others, and we're doing our best to balance what we believe is the opportunity that both Lisa and Tim have spoken about with all you have on your plate.